I may have failed to mention the patient did have a C797S upon resistance that was T790M loss, retention of that exon 19. That's important. So this patient does have a C797S. And we'll talk about how, as medical oncologists, we may manage what we're finding on these biopsies in terms of mechanisms of resistance to osimertinib. But let's back up a little bit and talk just about the patient's treatment up front. Do you guys feel comfortable starting osimertinib in a patient with asymptomatic brain mets, not even sending to radiation oncology?
I absolutely do. Yeah, I mean, she's getting a little borderline with that 1.2 centimeter occipital met. If it's a large met, I usually will SBRT it and then start osimertinib. I do not do whole brain anymore in these patients with osimertinib being available.
Paul?
I agree. I think one of the great things about this class of drugs and the experience that we've seen for CNS-specific disease, and this relates also to ALK rearranged lung cancer, are the phenomenal responses we see in the brain, which really allows us to spare patients from toxicity from whole brain radiation therapy, but allows us also to hold off on SRS for later on when we potentially might need it.
Yeah. Is there a threshold where we think, okay, you know, is symptomatic, more edema? Is there a time where we think, okay, it's time? Yes, osimertinib has a wonderful job.
Because it takes a little time, you know, for the osimertinib to work. And, you know, so if the tumor is quite sizable, there's a lot of edema, the patient's symptomatic, I think you don't have a choice. You have to actually go with local control with SBRT. But, you know, like I said, she's very safe. I mean, at 1.2 centimeters being the largest mass. But with the EGFR mutants, we tend to just see a diffuse small sub-centimeter mets everywhere. So I'm very comfortable treating those patients with osimertinib.